Ladies and gentlemen, I'd like to thank you very much for the opportunity to present at the MS at the Limits, which is one of my favorite MS meetings, and on a very important topic, that of melanoma and the MS patients and what the MS nurses should do about this. You see here in my first slide my affiliations. And this slide is a reminder to all of us that melanoma is a fatal, potentially fatal disease. This is Bob Marley, who died of a melanoma only at the young age of 36. So this is something that's very important. That's very important for all people dealing with MS. And I know that you, as an audience, are very familiar with MS itself, but perhaps not so much with melanoma. And because of that, I'm going to spend quite a lot of time in this talk speaking about melanoma. Just this month, we've lost Sean Locke, a very great comedian, also to melanoma, and his story is also quite relevant to what I'm going to speak about. He was single at the time. He had a one-night stand, and the lady with whom he had the one-night stand noticed an ugly lesion on his back, which turned out to be a melanoma. He lived quite a long time after that, but eventually he died due to this. So this is a serious condition. Just to illustrate how serious it is, I should say that it represents only 4% of all skin cancers. However, it is responsible for 75% or more of all mortality due to skin cancers. So it's indeed a serious condition. Unlike many other cancers, its frequency is on the rise and has been on the rise steadily. For example, only in the USA, between 1973 and 2002, its incidence has increased by 270%. It also has a high mortality, as you've seen from this statistics, that almost 10,000 deaths out of about 76,000 cases were reported in 2004 due to melanoma. So it has now become the 5th most common cause of death in men and the 6th most common cause of death in women. It has a greater mortality in men than in women, and it affects, just like MS, in fact, people who are young and middle-aged. So that's something to bear in mind. Again, if we go by the average susceptibility between males and females, it's about equal. However, it tends to be more common in females early on, before the age of about 40, but by the age of about 70, it becomes 3 times more frequent in men. Now, to the risk factors for melanoma. So there are, like many other diseases, including MS itself, it is a combination, an interplay between environmental and host-related genetic risk factors. So among the environmental factors, the single most important is sun exposure. This sun exposure is typically intermittent sun exposure. In fact, people who are exposed chronically to sun don't have a greater or may not have a greater incidence of melanoma, although they do have a greater incidence of sun-associated skin conditions such as actinic keratosis and basal cell carcinomas, for example. And it is important to know, because intermittent sun exposure is obviously the single most important modifiable risk factor for melanoma. A good marker of that is exposure in susceptibility and history of sunburn in childhood. In terms of what's the factor in sun exposure that's responsible for melanoma, it is the UV, the ultraviolet light, because of its genotoxic effect. So, and it doesn't have to be only sun. People who go to tanning salons very frequently are also at higher risk of melanoma. Also, people who receive PUVA treatment for psoriasis. So it's the ultraviolet light in the sun that's responsible for that. Now, coming to the risk factors associated with the host, the most important one, clearly, is the presence of nevi. So nevi are also called moles, and they're very common. And the presence of moles is associated with a higher risk of melanoma. People, and it's not just the presence or absence of moles, it's also, or nevi, it's also the number. There are people who have over 100 moles, and these people are 7 times more susceptible, more at risk of developing melanoma. And it's not just the number and the presence, it's also the size of the nevi. So the larger the nevi, the higher the risk. And also the presence of atypical features in the nevi, such as dysplastic nevi. They have a very high risk of becoming melanomas, 10 times higher. So in this figure you see to the left, there's a normal nevus. Towards in the middle, there is a dysplastic nevus, which shows some irregularity of the borders and a bit of raised. It's thickened and raised, and slight difference in colors. And to the right, you see a full-blown melanoma with all the atypicalities, with the irregular margins, with the color differences, and with a raised surface. So this is a table that shows the differences between a nevus and a melanoma. These usually are seen with a technique called dermoscopy by the dermatologist, which is a magnifying and lighted instrument that allows very good characterization of these lesions. So there's a pigmented network that looks in a regular reticular pattern in a nevus, but becomes irregular, and the holes and thick lines tend to be more irregularly distributed in melanomas. There are some dots and globules that normally are, again, regular and evenly distributed in the nevus and become irregular in melanomas. There are some streaks that are regular in the nevi but irregular in melanomas. And there is a feature called regression structure, which is a white halo around the lesion, which is typical for melanomas. And there are a few other issues that are very relevant to dermatologists when they do dermoscopy that allows them to distinguish between them. But when a nevus, even if it's not malignant, has some of these dysplastic features, it's always, the dermatologist will always prefer to take it out. Continuing with the risk factors, there's a very strong family history association in melanoma, And in fact, some of the melanomas are inherited in an autosomal dominant fashion. For example, those associated with the CDKN2A or CDK4 mutations. These are cyclin-dependent kinases, which are involved in the proliferation of cells in the cell cycle, and irregularities, genetic irregularities, can have been associated with melanomas. Usually these melanomas are superficial spreading melanomas, which is the most common pathological type of melanoma, and they tend to carry a better prognosis and tend to be occurring at a younger age. There is also a strong association with the phenotypic appearance. So essentially, the lighter the skin, the more likely, the higher the risk of developing melanoma. The so-called low phototype. These are people who have light skin, light eyes, they have freckles, they don't tan well, and they have high sun sensitivity. All of these comprises the low phototype, and this is associated with a 50% risk of melanoma. So in terms of diagnosis, this is as I mentioned, it's a very serious condition. It's a potentially fatal condition, but strangely, it is one of the most easily detectable types of cancer, because the skin, the majority of melanomas are cutaneous melanomas, so skin melanomas, and they are amenable to screening. So that is our very important role to help with early detection. And I will show you how important it is, because the prognosis depends on the depth of the tumor. And obviously the depth of the tumor depends on its duration. So early detection allows detection of a tumor that hasn't reached too much depth, and therefore it has a very good prognosis. So there is this very well-known Clark stages, which take into account the structure of the skin. So in this slide you see on the top layer of the skin called the epidermis, and then there is a lower layer of the skin called the papillary dermis, and then underneath is the reticular dermis. That altogether comprise the skin itself, the dermis, so epidermis and dermis, and then there is a fat layer underneath called subcutaneous fat. And the Clark classification has 5 levels. Level 1 is when the melanoma is only in the epidermis, and that is the most superficial layer, and it's called melanoma in situ. And when detected, it has a very good prognosis when it hasn't spread further down. So the second level means that the melanoma cells have just invaded the top layer of the dermis, called the papillary dermis. The level 3 is when it goes a bit deeper into that dermis at the junction between the papillary dermis and the reticular dermis underneath. And the level 4 is when it has spread into the reticular dermis. And level 5 is when it's already into the subcutaneous fat. And as you will see, there's a dramatic difference in terms of prognosis depending on these layers. There's also a classification that's based on the thickness. So thickness less than 0.75 millimeters, then 0.76 to 1.49, then 1.4 to 2.49, 2.4 to 4, and greater than 4 millimeters. And that corresponds very well, as we will see, with the actual Clark stages. And here on the bottom of the slide, you'll see the percentages of positive lymph nodes found corresponding to each of these thicknesses. And as you see, if it goes into the subcutaneous tissue, which is usually the stage that is over 4 millimeters, there is a 36% likelihood of metastasis into the lymph nodes, and that carries a poor prognosis. There is a good study from some time ago showing that these classifications correlate very well with each other and can be used interchangeably, although very often they're used together. And as you see the survival here, it shows the survival rates, and they're very similar. So Clark 2, 95%, Clark 3, 80%, Clark 4, 68%, and Clark 5, 47%. And almost identical survival rates when you go by the Breslow thickness. I have to say this is a little bit old, and I will mention towards the end that there have been some novel treatments for melanoma that have dramatically improved survival. So these are slightly older figures from before these newer drugs were available. So the most important thing, and the most important thing that we can teach our patients, including our MS patients, to do is to learn self-examination of the skin. And you could find lots and lots of sites. They're all very good, very self-explanatory, and so they all send the same message. It's a step-by-step, so it has to be done like many other self-screening techniques in a very systematic way, and it has to be done repeatedly. And it has stages, first the face, then sitting down the rest of the body, and then trying to look with a mirror in areas that are less visible by oneself. So, and there are many sites, including the NHS and Melanoma UK, that are very good. I have used the University of Rochester because it's quite clear language and quite simple and self-explanatory. So, first of all, they need to be in a room that's very brightly lit, and to use both a hand mirror and a full body mirror. Look both at the front and back of the body in the mirror. They should raise their arms and on both right and left side, and if women should also look under their breasts. They should look, and that's sitting position, they should examine back and front of the legs. They should examine the buttocks and the genital areas. They should look at their fronts and backs of their hands and fingers and fingernails. That is very important. I will tell you why. And the same with the feet, and also very importantly, the soles of the feet. I mentioned that people with light skin are more at risk of melanoma, and that people with dark skin are less at risk. But the melanomas that are present on the extremities, in particular on the soles of the feet, are equally frequent in, not very frequent, but there is no difference between light skin and dark skin people. It's a different type of melanoma, usually called acrolentiginous melanoma, and these So the sad story of Bob Marley is an example. He had a melanoma on his toes and back of the bottom of his toes. So it's important to look there. And then look at your face, neck, and scalp. So things to look for is particular for people who have nevi, who have multiple nevi. They have to look at asymmetry. If half of the mole is different than the other half, border irregularity, as we have seen in the picture, color, there's different colors, diameter, so the larger, the more likely to be a malignant melanoma, for example, more than 6 millimeters in diameter, and a lesion that is evolving, for example, a mole that looks different from the rest, the so-called ugly duckling. So all of this can be remembered with the mnemonic A, B, C, D, E, and this is something that we need to remind our patients to do. There are some other signs, for example, a mole that itches or is painful, a mole that bleeds or oozes, mole or skin mark that, again, the ugly duckling that looks different than many of the other moles, a sore that does not heal, and a mole or sore that becomes red and swells at the edges. So all of these are very important features that need to raise our attention. So what can we do next? So first of all, we can teach our patients, in particular the patients, as we will see, that are exposed to a certain disease-modifying treatments. But we can also do it ourselves. So when the patients come for their regular infusions or regular treatment, we can do that. So we can do our own examination using the same technique, the same systematic way of looking at the skin. The rest is for the dermatologist. So if we have any suspicion, we can refer to dermatology. They can do the dermoscopy that I've discussed. And very often, more recently, even with dermoscopy, sometimes it's difficult to get a long-term picture. Especially if there are many moles, it's difficult to look longitudinally to see what has changed over time. So because of that, increasingly one uses serial body photographs to see how lesions have evolved, that with a free eye or even this dermoscopy cannot really detect. So now the second part of the talk is the melanoma and MS. So the question is there an increased risk of melanoma in people with MS? And there are arguments, there are reasons to think that there might be. For example, as I mentioned, they have, and as you will see in a map, they have very similar geographic distribution. The phenotype, we know that people with low phototype, so people with light skin, freckles, light eyes, are also more at risk of multiple sclerosis. It affects a similar age group, young adults, and one difference that one might argue is that exposure to sun is a risk factor for melanoma, but perhaps a protective factor for multiple sclerosis due to vitamin D link. However, both melanomas and MS have been linked to vitamin D deficiency, perhaps not so much in terms of melanoma, in terms of susceptibility, but certainly in terms of prognosis and response to treatment. And both have been shown to have some response to vitamin D supplementation. So this is the geographic distribution in this slide, the geographic distribution of multiple sclerosis and of melanoma. And as you see, there's quite a bit of overlap, not complete. Melanoma seems to be a bit more spread in the northern hemisphere, at least, and in Australia. But it is, but there's many areas of overlap, and many areas where there is little melanoma and also little multiple sclerosis, such as in Africa. And also it's interesting that not only people with low phototype, so with light skin, are more susceptible to multiple sclerosis. People who, also, sorry, in the animal models of multiple sclerosis, usually animals with lighter skin and hair tend to be more susceptible. That is not always the case, but that led me some time ago to hypothesize that it may have something to do with regulation of melanin and the hormones that influence the levels of melanin, and that might have some protective role. So there have been studies looking at the frequency, at the increased or decreased incidence of melanoma in MS. And studies have been relatively different in results. In some studies, it has been shown to be increased. So this is a study that we did in a consecutive cohort of 658 patients. That was some time ago, 2004, done by then my medical student, Laura Edwards, who is now a consultant in neurological rehabilitation, specializing in multiple sclerosis. And we found then that melanoma was increased compared to the general East Midlands population from the literature. And there are some other studies that corroborate that. This is a study of US Department of Defense claims. And as you see, there was a slightly increased risk of melanoma. The hazard ratio was 1.7 with a confidence interval of 1.4 to 2.0. So, but there were studies that went a bit against these findings. So this is a more recent study by from the Danish register, showing that it was neither increased nor decreased. In fact, there were some differences because this register has been going on for a long time. So in the first part of the register, there seems to be some increase, but that did not was not shown in the second part of the register and of the duration of the register. And so altogether, the authors concluded that probably it is neither increased nor decreased. And the same data were generated from the Norwegian MS register. So again, neither increased nor decreased. And so these are very helpful registers, because in Scandinavian countries, almost every patient with multiple sclerosis is on this register. So that's quite powerful. And that led myself and my former PhD student and current good collaborator, Dr. Ali Manucherinia from the Karolinska Institute, to look very briefly, and these are not definitive and not published observations, at the Swedish registers. What is very helpful there is that Ali has access to both cancer and MS register of Sweden. So in the cancer register, he looked at he found 3,500 melanomas in 280,000 controls, and 67 melanomas only in 27,000 MS patients. So the conclusion from this, but it's not definitive, is that perhaps there is a lower frequency of melanomas in MS. This remains to be confirmed. However, what was very interesting is that all of these 67 melanomas occurred after the onset of multiple sclerosis, and that leads us to the next part of my talk, which will be brief, which will deal with the possibility of these being related to disease-modifying treatments for MS. We know that melanomas occur more frequently in people who are immunocompromised. So the strongest association between disease-modifying treatment and melanoma is natalizumab. There are probably about 200 cases by now, if we base ourselves on the adverse event reporting from the FDA, for example. There were 7 publications by 2007, which were all put together in this paper, and together also with the FDA adverse reporting. The mean age was 45, 77% were females, and they all occurred after treatment with natalizumab. But the duration of the treatment varied widely. The second most common association, and in fact these two are the only ones that are more consistent, more seriously to be taken, is fingolimod. Fingolimod, there are about 12 cases in the literature by 2019. And they all occurred after at least 1 year of exposure to fingolimod. This paper from 2017 shows 5 cases that occurred in Dutch patients on fingolimod. So if you think about other disease-modifying treatments, the reports are very sporadic. There's one report with alemtuzumab and one report with glatiramer acetate. So it is possible that these are just chance occurrence. And there's one interesting report with interferon. This is interesting because it developed when the patient developed neutralizing antibodies against interferon, suggesting that interferon in fact has a protective role against melanoma. And in fact, it has been trialed several times for immunotherapy for melanoma, and perhaps endogenous interferon, because when people develop neutralizing antibodies, it can also neutralize the endogenous production of interferon. So it is possible that endogenous interferon has a protective effect against melanomas. So the mechanisms are unclear, but it's interesting that the only 2 drugs that are more consistently associated with melanoma are fingolimod and natalizumab. Both of these drugs interfere with lymphocyte migration, and that may be the mechanism, because lymphocyte migration to tissues, in particular skin, because it's our largest organ and it's our largest immune organ. The migration is absolutely crucial for immune surveillance against infections, but also against tumors. So that is probably the mechanism, because in the Dutch series that I showed you the title for, all these patients did not have a dramatically low lymphocyte count, as we know could occur with fingolimod. So therefore, just the absolute lymphocyte count may not necessarily be related to melanoma. And there's also, just as a word of caution, there's a lot of experiments that have been done. In fact, fingolimod in the lab dish was shown to suppress the proliferation and the growth of melanoma cells. But in vivo, in real life, it had possibly an opposite effect. So we should not easily extrapolate the results from the lab dish to to the clinical results. But speaking about the lab dish, there are drugs like cladribine, for example, that has been shown also to reduce the proliferation of melanoma cells in vitro. So it's something that we need to, and the conclusion of that paper was that it may be unlikely to have an increased risk of melanoma with cladribine, but we should remain vigilant and we should not give up the skin self-examination. So this is another potential mechanism related simply to natalizumab. It has been shown that melanoma cells express the integrin alpha-4 beta-1, which is the integrin that's the target of natalizumab. And when it becomes invasive, the melanoma downregulates this expression. And this is exactly what happened when the cells are exposed to natalizumab, because it binds and downregulates this molecule, alpha-4 beta-1, and therefore it can contribute to the invasiveness of melanoma. There are programs for risk minimization with natalizumab treatment. For example, at 0.13 here, you could see that a patient must have a baseline as part of this touch study, which is an observational study for people on natalizumab. They should have a dermatological examination at the start. The rest is more related to the risk of PML, so I won't go into them. This slide just shows that there are new treatments for melanoma that are kinase inhibitors. There's also so-called immune checkpoint inhibitors, because they increase the immune response against the tumor by blocking molecules such seen in the panel A, PD-L1 and 2, and that are inhibitory, that inhibit T-cell responses in a natural fashion. So blocking those increase the T-cell responses against cancers, in particular melanoma. And these, as I mentioned, these have revolutionized the treatment of melanoma, have dramatically improved survival in even metastatic melanoma. However, unfortunately, they are associated with an increased frequency of autoimmune diseases. And there have been studies showing that they can also exacerbate pre-existing autoimmune diseases, including multiple sclerosis. So if we have a patient with multiple sclerosis who develops a melanoma, we should be very careful about the risk of exacerbating MS with these treatments, which are otherwise life-saving. So if it is a melanoma, obviously the drugs, as particular fingolimod and natalizumab, if they're on them, needs stopping. As I mentioned, we need to be aware of the possibility of exacerbations of MS if we stop the drug or if we start immune checkpoint inhibitor treatment. There are some safe options. Probably the safest would be interferon, which has in itself an anti-melanoma effect. There are some drugs that have been shown in vitro in the lab dish to be safe, to perhaps even block melanoma proliferation. So, and there are no reports with occurrence of melanoma under treatment with them. So there are options which can be discussed in multidisciplinary teams with the MS nurses and the rest of the team. We should still advise about vitamin D supplementation, as we do to all our MS patients, because they're good for both MS and melanoma. We should still advise about smoking cessation, because it improves the prognosis of both MS and melanoma. And we should certainly continue with self-screening of the skin, because one of the most one of the strongest risk factors for melanoma is a prior history of melanoma, especially when it arises into a pre-existing nevus. So the MS nurse can encourage and educate people about periodic skin self-examination, in particular in people with on drugs at risk such as natalizumab or fingolimod. They could reiterate the ABCDE. They can ask about changes and about new moles, etc. They can examine the skin themselves. They can refer to a dermatologist if they're worried about one of the lesions. And also they should make people aware and be themselves aware about the possibility of worsening of MS activity during the melanoma treatment. And with this, I close and thank you for your attention.